Thanks so much for joining us today. Appreciate your participation. This is our quarterly symposium through the USC Institute for Integrative Health and Wellness, through our Office of Religious and Spiritual Life at the University Park campus. Today's talk is focused on integrative approaches to sleep health, combining lifestyle redesign and CBTI to improve sleep disorders. And we have presenters in Dr. Lindsey Shomer and Dr. Anna Lynch, who will be introducing themselves later. And moderators will include Dr. Marilyn Thompson and myself at the end for the Q&A. So today we have a 90-minute session where we'll spend the first 60 minutes discussing and presenting, and the last 30 minutes with questions and answers by our participants as well as our presenters. So we'll go to the next slide. So our mission with the IIHW is to promote the health and healing of individuals, families, and communities that we serve through the advancement of the practice of integrative health, the science upon which it's based, and education of the healthcare practitioners and our USC community and other communities surrounding. Our vision in the USC IIHW is to transform healthcare by establishing a collaborative, holistic paradigm that promotes health and healing and integrates all aspects of human life: physical, emotional, mental, spiritual, cultural, social, and environmental. We always like to begin our symposiums with a land acknowledgement that the USC IIHW sits at University of Southern California and also at Children's Hospital. And we'd like to acknowledge the presence of the traditional, ancestral, and unceded territories of the Gabrielino Tonga peoples. And we recognize that these people were forcibly removed from their homelands. And we take this opportunity to acknowledge the generations that have been before, as well as the present day Gabrielino Tongva people, with humility, which recognizes with respect to the indigenous people, their histories, and their ties to the land. We pay respect to their past and their present, and let this acknowledgement serve as an ongoing reminder of the original inhabitants for where you reside. Remember that today you can get 1.5 CME credits using EADS. You can go in and sign in at www.eads.com. Use your sign in button, use this QR code. And our activity code is 71PEPO. And the credit is limited to within 24 hours of the presentation. Now, mind you, we do record the presentation. So if you end up missing some of the talk today, you can log into our YouTube channel later and see the Q&A or the rest of the talk, whatever you missed. But in order for you to get your credit, your CME credits, you have to do that within 24 hours of the presentation. So we can go to the next slide. I'd like to acknowledge the Executive Steering Committee for the USC Institute for Integrative Health and Wellness. I have been fortunate to be the director of the Institute for the last number of years. I was preceded by Dr. Mark Wiggensberg at USC. He's now at the General. And I just want to say thank you to everybody on this list, including our research staff, our clinicians, as well as Dean Varun Soni, who is our dean at the Office of Religious and Spiritual Life at USC. So thank you, everybody. Next slide. All right. I'm going to pass the baton over, but just for future reference, we have some book talks coming up, and we have some future symposiums coming up. So please log on to our listserv at USC IIHW and sign up, and you'll get to see all of our up-and-coming events. So I will pass this off to Dr. Marilyn Thompson to introduce our presenters and to kick us off. Thank you.
Hello, everyone. Thank you so much for joining us today for our winter symposium. I have the pleasure of introducing our presenters today. Dr. Lindsey Shomer and Dr. Anna Lynch are occupational therapy clinicians and scholars at the USC Occupational Therapy Faculty Practice. They both specialize in lifestyle redesign interventions for complex and chronic conditions. Their work focuses on sleep disorders, chronic pain, headache symptom management, mast cell activation syndrome, and dysautonomia. They have a shared commitment to advancing occupational therapy's role in sleep health. Together, they bring extensive clinical expertise, innovative program development, and a holistic client-centered approach that integrates evidence-based practice, mindfulness, and attention to health equity to support meaningful, sustainable participation in daily life. Please join me in welcoming our winter symposium presenters, Dr. Shomer and Dr. Lynch.
Thank you, Dr. Thompson. I appreciate the introduction. Both Dr. Lynch and I are very happy to be here today to present on this topic. It's a topic we're very passionate about, and we hope that there are some great takeaways, both for you personally and for some of the clients you serve. So as far as our learning objectives for today, we are going to go over, we're going to start by providing an overview of two commonly used interventions, lifestyle redesign and cognitive behavioral therapy for insomnia. These are both evidence-based approaches, and we want to really highlight the framework that is utilized within each of these interventions. Then we'll really dive into how lifestyle redesign complements CBTI as a 24-hour whole person approach to improving sleep. We'll talk about some of the evaluation and assessment tools we use with our clients and really go over how the integration of both of these evidence-based strategies is what we find to be very effective with our patients who are struggling with insomnia. We will present a case study, and then we'll talk about strategies for program development as well. So kind of leading into the presentation overview, we'll start with lifestyle redesign, we'll touch on CBTI, and then we'll really focus on how merging these two techniques is beneficial. So let's start with what is insomnia and really understanding the definition. So many people, I think especially in today's day and age, are reporting difficulty with sleeping. But insomnia is defined as the subjective experience of difficulty falling asleep, staying asleep, or waking up earlier than intended. And so a client often comes to us reporting that dissatisfaction with sleep quality, and that could be in any one of those areas. They're having the difficulty falling asleep initially, maintaining sleep throughout the night, or they're waking up earlier than they had hoped for. Beyond that, an important component is to also them indicating that there's some impact on their daytime function. And so we'll often hear that this is an experience they're having more or at least 3 nights a week for at least 3 months, despite adequate opportunity for sleep. So the opportunity is there, the time is there, but they're not getting that sufficient or effective quality of sleep. So in looking at the treatments for insomnia, there's a number of pharmacological and non-pharmacological recommended interventions, but cognitive behavioral therapy for insomnia is one of the frontline approaches for treating insomnia. And typically that is an intervention that is provided or administered by a psychologist historically. We as OTs, Dr. Lynch and I are both occupational therapists. We have incorporated that into our occupational therapy framework, which we use lifestyle redesign intervention in our practice. And we've found that really combining these two approaches has been effective. And so that's what we really want to leave you all with today is how this combined approach can help clients. So let's start with lifestyle redesign and occupational therapy. Before I define lifestyle redesign, I do want to take a step back and just introduce occupational therapy as a discipline and a profession. So we as OTs, we really look at how any sort of health condition is impacting a person's ability to do the things that they want to do, need to do, or are expected to do in a given day. And we work with clients to help them get back to that prior level of function. So that's sort of our discipline as a whole. Within occupational therapy, there are a number of different interventions and frameworks that we utilize, but today we're mostly going to be focusing on lifestyle redesign. So lifestyle redesign is an occupational therapy intervention framework. I'm going to have you go back to that slide just so I can define it. That promotes the awareness of the relationship between everyday activities and health and guides people in the process of orchestrating occupations, habits, and routines to enhance health and well-being. So we're taking a very close look at people's daily habits and routines and how those things are either health promoting and helping them manage any health condition that they're dealing with, or how those habits and routines may be health deterring and actually negatively impacting the management of their health conditions. So we use this and apply it specifically to insomnia. This intervention framework is defined by core characteristics, core domains, and core techniques. So the core characteristics of the intervention framework is, again, it has a distinct focus on daily activities and the orchestration of those routines. We apply this lifestyle redesign approach to a variety of lifestyle related challenges. We use a very patient-centered approach and really facilitate that therapist-client collaboration. We really see the client as the expert in managing their life. And so it's a very, again, patient-centered, individualized approach. And then our concern or the outcomes we're aiming for are associated with a variety of health relevant outcomes, which we'll touch on in a minute. And in order to use lifestyle redesign as an intervention, it is something that must be administered by an occupational therapist who has advanced training. There's a certification, and so anyone that is doing lifestyle redesign must be certified in lifestyle redesign. The core domains are kind of the areas or the topics that we typically cover with our clients. So at a higher level, the 5 core domains are focusing on those occupations and habits and meaningful occupations. We also look at the specific occupations that are relevant to wellness and chronic condition management, eating, exercise, sleep, medication management, things like that. We definitely focus on psychosocial well-being and mental health, and we definitely know for sleep, managing things like stress and anxiety and mood play a key role in having good quality sleep. We also look at environment and context and how those things could be impacting a person's ability to manage a chronic condition, and also things like advocacy and healthcare access, how clients are communicating effectively with their healthcare providers, but also with peers, colleagues, family members, things like that. And then lastly, the core techniques that we use in this intervention are patient education. So doing a lot of educating around how something like our eating routines could be impacting sleep, or why is it so important to manage stress in order to improve sleep. So we really want patients to be understanding of the relationship there. To help support the behavior change process. So we want them, if we're going to make a recommendation for change, we want them to understand the why behind that recommendation. We'll also engage clients through occupational self-analysis, so helping guide them to reflect on how their activities and their routines are impacting their sleep, again, to kind of support that behavior change process. We'll use narrative reasoning, having clients kind of share and report on their personal stories and experiences and put value and meaning to those things to support behavior change process as well. Occupational orchestration, so actually engaging patients in the evidence-based strategies that we're recommending so they can experience the benefit themselves, engaging them in problem solving and activity analysis, really looking at the breakdown of a task and how every single step of that task could be impacting their health and well-being. And then autonomy enhancing communication. So because so much of what we do is focused on behavior change, we often use motivational interviewing to really help patients move through those stages of change to implement the strategies that we are introducing them to. And then something to note is just to know that lifestyle redesign as an intervention may not be appropriate for all populations. Individuals with cognitive deficits or young children may not be appropriate for the intervention because it does require that sort of problem solving and self-analysis and self-awareness that these particular populations may not be able to participate as effectively as other populations. And then looking at the outcomes that we're really focused on. So in going through the lifestyle redesign process, our goal is to improve a person's quality of life, satisfaction, participation, all with the goal of health promotion, chronic condition management, and improving overall health and well-being. So that's usually the outcomes we're aiming for. As an overview, all of the different topic areas that we might address with a client in a session. You can go to the next slide for me. We might address all of these with our clients, or we may just focus on a handful of them. So if someone's coming in with insomnia, we may primarily focus on sleep and rest routines, but we may also pull in topics like how medication management might be affecting them, or how their physical activity routines might be impacting them. And so just depending on the evaluation and the areas of deficits and functional challenges that we're identifying, we may address all or just some of these topics. And then lastly, as the intervention, kind of if you were to observe a lifestyle redesign session, the progression of what that would look like is it usually starts with that patient education component, really giving the patient the understanding of why we're talking about stress and how it relates to sleep and the pathophysiology and how those things are interconnected. We also provide education about the evidence-based strategies and recommendations so that we can then engage them in that direct patient experience. So if we're going to talk about self-regulation or practicing some mindfulness strategies before bed, we would then engage them in the practice of that activity. Then we would do some personal problem solving. How can they actually integrate these recommendations into their daily routines? Thinking about potential barriers, potential challenges that may come up, and really problem solving of how to incorporate that. And then we always finish our sessions with some goal setting so that they can then practice these recommended strategies and then come back to their next OT session and either report on how it helped or discuss what challenges arose that we need to continue problem solving through. So with that, now kind of diving into the specific sleep interventions that are addressed within that lifestyle redesign framework. These are all of the different sleep specific topics that we would typically go through with our clients. So we'll touch on each of these in a little bit more detail, but we'll usually start with sleep education. You could go ahead to the next slide. And within sleep education, again, this is such a foundational starting point with our clients. Before we can jump into recommendations, we want them to understand what is typical sleep function meant to look like, what are the typical sleep stages, and what are the things that influence sleep. So explaining the sleep drive process to them and our circadian rhythm regulation and how those things play a role in an individual's ability to even achieve higher quality sleep. With the sleep drive, we help people understand that from the time we wake up until the time we go to bed at night, we really need to be building up this need for sleep so that when we get into bed, we're able to achieve sleep because there's a high enough need to get that sleep routine in place. And understanding that things like naps or being sedentary or not expending enough energy during the day could really have a negative impact on their sleep routines. So then we'll talk through like, are you expending enough physical, cognitive, or emotional energy? What are things we can do to strengthen your sleep drive so that there's an adequate enough need at the end of the day to achieve sleep? And then also talking through our circadian rhythm regulation and that 24-hour cycle of the sun and the moon, and how really our activities should align with that cycle. During the day, we want to be doing things that are energy expending and alerting and activating and stimulating. And as we transition to the nighttime, we really want to be winding down and preparing the mind and the body for sleep. So we start with that foundational education piece. We often will discuss sleep wind down routines with our clients. Again, sort of providing some background information and really understanding that as we prepare for sleep, it's important for our brain and our nervous system to engage in activities that are promoting that parasympathetic nervous system activation. We want to be engaging in things that are relaxing and telling our mind and our body that this means we are going to sleep. So we often will help clients establish these wind down routines that progress from an order of higher stimulation to more moderate stimulation to really low intensity or low stimulating activities. And so the order of the activities matter, the type of the activities matter, but then also the consistency. Doing these things in this order each night is another way to signal our brain and our body that this means I'm preparing for sleep. And so in this example provided here, it's the transition from work and getting home, and then transitioning to those more moderate activities of eating dinner, watching TV, engaging in self-care routines, but then finishing off with something that is really, again, promoting that parasympathetic nervous system, gratitude journaling, deep breathing. And going back to that individualized approach, this is going to look different for everyone. So really working with clients to understand what are the activities that are going to make the most sense for you in your routine. Then we'll also address things like looking at a person's sleep environment. So we'll talk about how things like light and sound and temperature all play a role in our sleep quality, and talking through any environmental modifications that may need to be made to support their sleep routines. And then a big component of CBTI, which Dr. Lynch will talk about shortly, is just evaluating what types of activities are happening in the bedroom environment. And really reducing what we're doing in our bedroom to really just minimizing it to sleep and sex. That's really the only thing that should be happening in our bedroom environment. So again, working with clients to modify their environment or where they're doing their activities in their home. We also look similar to environmental setup, sleep positioning. If patients are coming to us with other chronic conditions such as pain or migraines, sleep positioning may be a key factor in making sure that they're getting sleep in an effective way that isn't exacerbating their pain symptoms. So we may also look at things like sleep positioning to promote neutral posture and reduce any sort of pain trigger. And then lastly, we're not going to go into all the details of these different lifestyle factors, but if talking about just the sleep specific interventions isn't enough to totally fix their sleep challenges, we then need to take a step back and look at these other lifestyle factors. How are their eating routines impacting or playing a role in their sleep? And how is their physical activity or exercise routines playing a role? The timing of it, the type of it, the frequency of it, things like that. Medication management could be impacting sleep. Stress, definitely a barrier to sleep routines. And then also looking at things like time management skills, scheduling, planning, prioritizing, and social factors. So all of these things can have a secondary effect on sleep. So I'd say from a lifestyle redesign approach, we're starting with targeting the sleep specifically, but if we need additional sort of assessment and intervention, we may take a step back and look at these other lifestyle factors that could also be impacting their sleep routines. So that's the lifestyle redesign umbrella component. I'm going to pass it over to Dr. Lynch to then dive into CBTI specifically, and then how we combine these two.
Awesome. Thank you so much, Dr. Shomer. And it's so nice to be with everyone on Zoom today. And I'm so excited to talk about CBTI. So if I were to define cognitive behavioral therapy for insomnia, or CBTI, it is known as a blend of cognitive and behavioral techniques that was developed as a therapy to treat insomnia through a couple different ways. These techniques strengthen that inherent sleep drive. They regulate circadian rhythm. So kind of calling back to that sleep education piece we covered, it really strengthens the physiological processes of sleep, and also to reduce sleep-related anxiety and to break the conditioned arousal response cycle that contributes to the perpetuation of insomnia. And I will define conditioned arousal in a few slides later. The good news about CBTI, there is a preponderance of evidence for it. Research has found that in the short term, so the first 4 to 8 weeks of treatments, it is as effective in treating insomnia as sedative hypnotics. Then longer term evidence indicates that it is more effective than sedative hypnotics, which then led the American College of Physicians to recommend CBTI as the frontline treatment for insomnia, meaning it is sort of best evidence-based practice to trial CBTI before turning to pharmacological interventions. It obviously has a lot of barriers to it with things like clinician availability, insurance barriers, but that is where the evidence currently stands. To go into some specifics as well, those were two landmark studies that looked at sort of larger swaths of data, found from 2 meta-analyses, looked at subjective effective sleep latency, so how long it was feeling like it took someone to fall asleep, and also the duration of wake after sleep onset. These two studies found that reduced from 60 to 35 minutes at treatment end. So those changes corresponded to a 50% reduction in insomnia symptoms with pre to post effect sizes of 1.0. So pretty significant. These were some of the earlier meta-analyses on CBTI. So something that you'll sort of see in later data versus this earlier data is that we now include baselines around early morning awakening insomnia, or EMA. The duration of those were lumped together with wake after sleep onset. So just a note about that data. So now I'm going to go a little bit more into the cognitive behavioral theoretical conception of insomnia. So why this therapy even developed in the first place. Insomnia is a threshold disorder. It's a pretty important evolutionary function that we all have. Anyone can develop insomnia at any point in time in their life. You're either above that insomnia threshold or you're below that insomnia threshold. So the cognitive behavioral model of insomnia says that, if we have this threshold, people can be living their lives with predisposing factors. There can be a genetic component. It could be a history of anxiety. There could be some social factors as well. Shift work, high stress job, that might just increase your risk of insomnia at a baseline, but might not be enough to tip you over the edge. If someone develops insomnia, usually there is in that second P is a precipitating factor or factors. So that's when we look at, okay, when you first developed insomnia acutely, what was getting you over that threshold? And we are thinking about that in a biopsychosocial way. So that could be anything from illness to injury, to stress. Sometimes that can be major stress, a loss, a move, a death in the family, or the accumulation of lots of factors as well. And this can also be other major life changes like a new baby, parenthood, taking on a caregiver role, taking on shift work. I've had somebody whose precipitating factor was actually a really bad case of jet lag. So the second P that we look at are what got them over the edge, what precipitated that acute insomnia. This third column over, we have now this dark gray that's emerged on top that we consider perpetuating factors. So this is where we really hone in on the cognitive and behavioral factors that are now keeping your insomnia going. Because if it was just someone's precipitating factors, which never really last forever, they may last a long time, but they don't last forever. So one would think if those went away or decrease, then someone's sleep would get better, but it often does not. It can become chronic. So that's when we look at what has now developed in this person, in what they're doing and what they're thinking about their sleep, that's actually now perpetuating the insomnia, keeping them awake. Some common things we look at are something called sleep extension. So this individual may start to spend more time in bed. That could be sleeping in, naps, going to bed earlier, or simply lingering in bed when they cannot sleep. That may lead to doing incompatible behaviors with sleep in bed. This may also lead to cognitive changes. So there are changes in beliefs about sleep, that sleep takes effort to achieve, that sleep does not come easily. There may be fears about I'm completely unable to function the next day. So this is where we see, again, behavioral and cognitive changes that are now actually perpetuating the insomnia. When that happens enough and enough and enough times, because this is happening in a very specific environment with environmental cues. It's nighttime, it's dark, you're in a special environment, your bedroom, there's the bed. So now all of these cues start to take on a new meaning. So in the fourth column over, we have that very, very dark gray. that's now emerged on top, keeping you above the insomnia threshold. And that's what we call the conditioned arousal response, or the Pavlovian factor of insomnia. These things actually start to cue you into a more upregulated state that is incompatible with sleep. So let's look a little bit then at the role, like how do we get to conditioned arousal? Actually, can you go back one, Elena? Yeah, perfect. And I'll cue you for when to add on. So this is taking the classic Pavlovian experiment, right? That we have an unconditioned stimulus that was presented to a dog. So in this case, it was some food, and that resulted in upregulation of the dog's physiology. It got excited, it started to salivate. Then the dog was presented with a neutral stimulus, a bell. A bell didn't have any meaning for the dog, so we got no change in its state. When the dog was presented with the food and the bell, we had that upregulation in its physiology, the excited response, the salivation, that happened again and again and again and again. And then once the bell, which was now a conditioned stimulus, was presented to the dog, we had that change. So you may already be going there, but let's look at very specifically how that is applying to sleep. You can hit the first, yeah. Okay, so let's think about, I know like phones are all like a very common metaphor, so I don't mean to like drive it home, but it's sort of the most readily available one to us. Phone is a stimulating, is an upregulating stimulus for many reasons, but chances are you're going to be in a little bit more of an alert state if you have your phone on you. So we have that stimulus. Then we have the bed. Before insomnia, that's usually a neutral stimulus, might not bear either a ton of meaning to you, or before insomnia, it might actually be a very positive stimulus for an individual, actually a cue for a more relaxed state. And then, right, if you're pairing the phone with bed, that's happening over and over and over again, that is going to result in the bed itself being a cue for an upregulated state that is incompatible with sleep. So that is part of what we're looking to break with CBTI. So then what are the actual components? What are the behavioral and cognitive therapies that we actually do? So this is the menu of what is typically considered the components of CBTI. The first two are the main behavioral therapies. We have sleep restriction therapy and stimulus control. Each component of CBTI, I should say too, have been studied as monotherapies. So each component does have research behind it of how effective it is as a standalone therapy. Sleep restriction is the most effective monotherapy. It has the most research behind it as effective by itself, then followed by stimulus control. So the behavioral therapies are actually the most effective techniques. It's the first ones we want to go to. Then we have sleep hygiene, cognitive therapy, mindfulness, and relaxation training. Sleep hygiene, it's included because it supports the changes. Sleep hygiene is almost like hand hygiene. Like it doesn't, is it good to be washing your hands? 100% absolutely. Is it good to be practicing sleep hygiene? 100% absolutely. But sleep hygiene doesn't treat insomnia. It supports everything else that we're doing to treat the insomnia. Then we have cognitive therapy, which is addressing what inaccurate or maladaptive beliefs about sleep the individual has that's contributing to the perpetuation of insomnia. The cognitive therapy also includes cognitive regulation strategies to manage that cognitive arousal. And then mindfulness and relaxation training is included as well, just to really increase the scope of strategies we look at to support the individual reducing that arousal state around their sleep routines. So now I'm going to go a little bit more into sleep restriction therapy. So this is, again, it's the most effective monotherapy. So if you were to do like absolutely nothing else but sleep restriction, it has the most evidence behind it. And what it is treating, so in this graph, this is looking at someone's total time in bed and total sleep time. Somebody with insomnia typically will be spending an incompatible amount of time in bed, so giving themselves a pretty long sleep opportunity, which is that the pink shaded part of the graph, with a impaired sleep ability, so the blue shaded part of the graph. That is doing right quite a few things to keep their insomnia going by extending that window of time for sleep opportunity with an impaired sleep ability. It's contributing to the dysregulation, further dysregulation of someone's sleep system, right? Their sleep drive and their circadian rhythm. And it's giving them more time in bed to engage in sleep incompatible behaviors. Sleep restriction therapy is the process of using a standardized sleep diary. It's called the consensus sleep diary, where the individual is recording by their own perception. This is also really important, not by a watch, not by their Garmin, not by their Apple Watch, not by their Oura Ring, but how their sleep feels. That's how they're recording their data. We then use their data to determine what is that time in bed window they're giving themselves and how much time are they actually experiencing sleep. We then use that data to give them a prescribed time in bed and a prescribed time out of bed. Ideally, that is now getting their sleep opportunity closer to their sleep ability. So you can see in this graph, right, when we get to chronic line at the bottom, where they have a really big sleep opportunity window, time in bed window, but it really impaired sleep ability. By week 1, we are lowering their sleep opportunity to match their sleep ability. And then getting them on a prescribed time in bed and prescribed time out of bed. And that is going to turn that sleep drive and circadian rhythm regulation and strength into overdrive. We then meet every week to titrate their sleep prescription. So depending on what their sleep diary says, the number we ultimately look at, or the ratio between someone's time in bed and their total sleep time, that is called their sleep efficiency. And we use their sleep efficiency to determine, okay, can we titrate up, add on about 15 minutes to your time in bed? Do we need to keep you where we are? Or did we get the sleep prescription wrong? Do we actually need to go down a little bit and get you at a more accurate sleep prescription? So that is sleep restriction therapy. This is the consensus sleep diary. So this is a standardized diary that we use for the individual to track their bed and, again, how their sleep felt like, the subjective experience of their sleep versus, looking at a watch or a tracker and transposing it. It's very important that they're using their perception of their sleep. Stimulus control. What I think is really important about stimulus control is that you'll often see it on sleep hygiene, like handouts or like listicles. It's not sleep hygiene. It's really a behavioral practice that, when done repeatedly, it can also help treat insomnia, but it has to be done every single night. So some of the tenets of stimulus control, if you were to do it, is to go to bed only when sleepy. If you are unable to sleep, you get out of the bed, engage in something that's pleasant yet not super stimulating, and return to bed only when sleepy. It is the elimination of all sleep incompatible behaviors in the bed, so using the bed for sleep and sex only, and waking up at the same time every day, regardless of how much you slept. And eliminating naps as possible. This is standard CBTI tries to eliminate naps. As a caveat, there are situations in which we do include naps as part of someone's management plan, but standard does try to reduce naps as much as possible. And again, I think what's sort of a misnomer about stimulus control, when you see the strategy of get out of bed when you can't sleep, it's listed on sleep hygiene, is that getting out of bed when you can't sleep, it's acting upon these perpetuating factors of insomnia and trying to break that conditioned arousal response, trying to break your bed as a cue for being in an upregulated state. And if it took somebody, right, if an individual has chronic insomnia, this has been going on for like at least a few months, if not much longer. So if they've been walking into the woods for a certain amount of time, they're not going to walk out of the woods in one night. This is not a strategy that like gets you back to bed necessarily. It is a behavioral therapy. And then I want to touch upon the other sort of main technique I did want to focus more time on is the cognitive therapy piece. How do we do cognitive therapy around sleep-related beliefs? So the goals of cognitive therapy is to provide education on sleep, what it is, what it isn't, and maybe debunk some of the dysfunctional or maladaptive beliefs that somebody has, and also to look at some of the sleep myths that are just like circulating out there. We'll use cognitive therapy to address safety behaviors an individual may have. And then this is where we're starting to look at, you know, how can we reduce their cognitive arousal? And sometimes cognitive strategies are helpful for reducing cognitive arousal. But then again, sometimes we're also looking at other ways to reduce it, well, more mindfulness-based strategies or relaxation training. Okay, so yeah, let's look at the education and debunking dysfunctional beliefs about sleep. So there actually is an assessment that we use called the dysfunctional beliefs about sleep assessment, or the DBAS. And it's a list of different statements about sleep, and the individual rates themselves on the 0 to 10 scale of how much they would personally agree or disagree with each statement. Then we are able to go back and look at, you know, are there actually some myths that they are really that really have a hold of them and putting some pretty harsh expectations on their sleep, or contributing to maybe even like performance anxiety around your sleep. So we have content at our clinic that will go over to help debunk, especially the most common ones of like, 8 hours is the magic number. I need to wake up feeling refreshed right away. I shouldn't be waking up at all during the night. All of those are actually, you know, myths about sleep. And then we can also spend some time looking at safety behaviors. And what are safety behaviors? Safety behaviors are behavioral coping strategies that someone engages in to manage insomnia symptoms or manage beliefs about insomnia. So around sleep, if somebody has fears of, you know, I won't be able to function the next day, in order to protect themselves, so right, they're trying to keep themselves safe from that fear happening. This is where somebody could have a nightcap to help them fall asleep, even though, and alcohol is a depressant, but it will absolutely make your sleep quality worse. They may cancel events the next day, call in sick, reduce what's on their schedule the next day, take things easy, cancel social plans. So all of that may be quite alleviating, that they're protecting themselves, keeping themselves safe from that fear of becoming true. What it does, though, it's also confirming those negative beliefs. So it's confirming the inability to manage the negative effects of insomnia. It prevents the individual from experiencing any contradictory evidence, so evidence that might actually show that those beliefs, even though there might be truth to aspects of those beliefs, on the other hand, those beliefs might not be 100% accurate, and you're depriving yourself of the ability to acquire that evidence. And it's reinforcing the belief that poor sleep is catastrophic. Sleep is obviously very important. It's a pillar of health. Short-term poor sleep is remediated by adequate sleep. So it can reinforce the belief that poor sleep is a catastrophic event. So, and it can be kind of tricky to elicit those safety behaviors from the individual. So oftentimes when I'm addressing this with somebody, I'm trying to elicit, what are you afraid of happening, or when you're stressed out about your sleep, like tell me more about the stress. Sometimes it is around, I'm so stressed I can't function the next day. Some people find like it's just uncomfortable that I'm not sleeping. I just get frustrated. I'm so frustrated that I don't know when it's going to happen. That unpredictability might be what's stressful for them, even if they feel like they could function okay. And then I'll inquire, what do you do to deal with that? And that tends to give us some answers, because safety behaviors can also be invisible, right? It could be something like checking the clock. It could be something like trying to plan your next day. If you feel that, okay, if I'm going to be tired, what do I make sure I have to do to make sure the day goes well? It might be suppression of thoughts, an invisible action. So telling yourself, oh, okay, don't be worried, don't be worried, don't be worried. That thought suppression. So safety behaviors can also be invisible. So once we identify their safety behaviors, we can then look at the beliefs underlying those, see if we can maybe challenge the accuracy of those beliefs, and then develop our plan to discontinue the use of a safety behavior. Figure out, what will we do instead to reinforce the more accurate or flexible belief. And again, cognitive therapy can be used to address cognitive arousal. Doesn't have to be the cognitive strategies don't have to be the only one. This is really now where we start to get into territory of what is going to work best for the patient. How is the patient going to respond to the strategies that they practice in between their sessions? So a couple different strategies we had that are, again, on the more cognitive side, sleep preparation strategies. This might be scheduled worry. So actually setting in worry periods where they do kind of let their thoughts roam, work on their problems. There is a technique called constructive worry, where they actually, similar to scheduled worry, they set aside time. It's a limited amount of time where they really are looking at their problems in a more structured way to figure out, is there anything they can sort of immediately do, not that night, but the next day, or these problems that they have to live with, practice acceptance around. So then when those thoughts come back up at night, you are able to point to what you did during constructive worry and say, I spent time on my problems, but I was better at problem solving because it was earlier in the day and nothing else could be done at night. Sometimes this also might just look like really open-ended writing, just doing like a morning pages, kind of keeping your pen moving so you're just getting thought out, or like the brain dump, letting thoughts out, pre-sleep writing. Sometimes this also looks like getting them in the habit of writing down their to-do list for tomorrow. So a lot of this is about externalizing their anxiety of what's on their mind, even if it might not be always major, but again, this cognitive arousal is just the fact that they have this association. These are conditioned stimuli of the nighttime, of sleep, of their bed, of just upregulating their nervous system into a more active state. So it doesn't have to be necessarily like anything major that's on their mind to be in a state of arousal. And then we also have some of the sleep onset strategies to address cognitive arousal. Leaving the bedroom is back on here as a strategy because sometimes that cognitive arousal can happen so quickly as they approach the bed and they feel that arousal kick in, and leaving the bedroom, kind of practicing removing themselves from the stimuli, re-regulating, then approaching again. Sometimes even just leaving the bedroom brings that arousal down. Counting sheep is on here. The reason why is this is considered is this technique of the articulatory loop. If a thought is feeling really like sticky, it's simply replacing that thought through the repetition of something more neutral. So sheep, I don't know if is entirely neutral with the associations of that's not something you do when you can't sleep. So the articulatory loop is just, it can even be the repetition of a word, read, the, so something else more neutral that's repeated instead. And then we also have cognitive distraction. So using like more visualization, There's also a technique called cognitive shuffling, which is choosing a short word. So say like home, H-O-M-E, for each letter of that word, you try to think of as many other words that start with that letter. So for H, you try to think of as many words that start with the letter H. When you get distracted or can't think of anything, you go on to O, to M, to E, and then check in with how you feel after. And then also to cognitive arousal. Again, I didn't really cover everything. I just wanted to sort of stay in more cognitive framework, but this is also, again, where we have mindfulness and other even more relaxation body-based strategies are also welcome here too. CBTI does have some contraindications and also some cautions, things that we just want to be aware of. The biggest contraindications are around bipolar and epilepsy or history of seizure. The reason why is chances are if you are doing any sort of behavioral intervention, so looking at the behavioral techniques of sleep restriction and stimulus control, short term, because you are creating such a major change around someone's behavioral patterns and their sleep, in the first 2 weeks of treatment, you're almost guaranteed for the individual to have a short-term loss of sleep. For bipolar disorder and epilepsy, that is short-term sleep loss is a risk factor for an exacerbation of symptoms. So something like sleep restriction or even stimulus control, it's mostly sleep restriction, but even right when there is anything that increases the risk of short-term sleep loss, you're increasing the risk of manic episode for bipolar disorder and increasing risk of seizure for epilepsy or history of seizures. So those are some contraindications that are built in there. And then other things that are cautions are any sort of like parasomnias, so sleepwalking, sleep talking. If an individual has a fall risk or history of panic disorder, again, when we're intervening on someone's sleep patterns in such a significant way that could increase in the short term sleepiness, there is an associated risk factor for all of those conditions as well. So it's something that we always try to account for. Okay, so let's look at merging the two techniques together. So CBTI, right, as sort of just laid out, it's like very, very, very zoned in on sleep in a specific way. Pairing it with lifestyle redesign we're able to broaden out more to a 24-hour approach, giving some more time to some of the daytime factors that's playing a role with sleep downstream. A lot lifestyles redesigns collaboration that's emphasized in all the techniques we use in lifestyle redesign is also really targeted to strengthening a patient's inherent motivation for change and independence in managing change, which I think is a really nice complement to just improve adherence to the more challenging aspects of treatment. You know, we have people fill out a diary every night that has several rows, and I'm going to tell you, don't wear your Oura ring. So that's hard work. Same thing with stimulus control and sleep restriction. Those are things, it's hard work making changes in such a immediate manner that's going to make you sleepier for about a couple weeks. And then, you know, other sleep disorders that we see, I know we're focusing on insomnia, but other sleep disorders that we see too, can have some really challenging behavioral changes that come with it, like sleep apnea, and someone has a CPAP machine on. It can take a really long time to find the tolerance for it. And then when there's the presence of insomnia in the setting of other chronic conditions that might require lifestyle changes to support, that's also where lifestyle redesign comes into play too. We can look at this bidirectional relationship to somebody's chronic condition and how that's affecting their sleep, but also how someone's sleep quality might also be a trigger for another chronic condition they might have. So with kind of merging the two techniques. CBTI is, evidence-based protocols around sleep, but lifestyle redesign is really collaborative approach, an individualized approach that focuses on the process of radiating change. We can think of the comparison of, a cycle like this of how sleep can impact so much over 24 hours, and combining the two techniques, we're trying to change this whole cycle from something that's more maladaptive. And you can go to the next slide, to create radiating change that then kind of leads to a whole cyclical change, not just in sleep, but hopefully too in some of these other areas of their life, if that's what a client is looking to get out of therapy. So I want to walk you through, before our case study, just some things that we look at in our evaluation. We're always trying to look at some of their sleep baseline. So, what's the range of their sleep wake time? What could be the range of their getting into bed, getting out of bed? Sleep onset latency is how long it feels like it takes them to fall asleep. We want to see the number of wakenings after initial sleep onset, the duration of wakenings after sleep onset, so how long that's lasting. Do they have any early morning awakenings? And if so, how early can they be up before their desired time, and if they're napping? And also, I included all the abbreviations because you will encounter that in behavioral sleep medicine world. Those are common abbreviations for all of these terms. Then we're also looking at, their medical history, any additional symptoms in addition to their challenges falling asleep, staying asleep, waking too early. Are they experiencing any irritability, functional deficits, cognitive symptoms, any relevant comorbidities as part of their medical history? And then if it's an insomnia referral, I'm already thinking about that 4P model of sleep. What might be some of especially their precipitating factors? What was going on in their life? If they haven't had insomnia their entire life, and some people, right, like this goes back to childhood. If it doesn't go back to childhood, I want to know like what is going on in their life. What can they recall was happening when they had acute insomnia? And I'm already starting to suss out for what might be some of those perpetuating factors, some of the things that they're doing and the changes around their sleep beliefs that are perpetuating their insomnia. I want to know what their medications are, both if they're taking a sleep medication, what they're where they are in their process of change around a sleep medication. If it's something they want to keep as part of their routine, or they want to titrate off it one day. And if any of their other medications contribute to either feelings of sleepiness or are insomnogenic, that's also important to keep in mind. I want to know if they have a history of a sleep study, especially if they might have a secondary or an additional sleep disorder, or we're suspecting there's a presence of another sleep disorder, and any fall history or fall risk. Then I'll be looking at what we call their occupational history. So I want to know their occupational patterns and roles in day-to-day life. So in general, what does a typical day look like for them? What's the timing and regularity of their routines, if any? So that's, eating, physical activity, it's what they like to do for leisure, social participation, work. And the self-regulation piece, I'm trying to figure out too, do they have stress as part of daily life that's contributing also to their insomnia? Or this is common too with sleep related anxiety. They might feel like, I take care of myself great during the day and I don't have stress in my daily life. I'm just stressed about whether or not I can sleep at night. So that can show up too. I want to also know too, especially what does their evening look like? What type of sleep wind down routine are we working with? And do they have a sleep supporting environment, or some of the barriers to their sleep found within their environment? Assessments that we'll use are the Insomnia Severity Index. The Sleep Disorder Symptom Checklist 25 is amazing because that is a screener for like all the sleep disorders, or for many sleep disorders. So that's always really helpful for us to figure out, especially time of eval, is there something else also that we're missing in terms of other sleep disorders they might be experiencing, and do we need to get somebody into a sleep study? The Canadian Occupational Performance Measure is an OT specific outcome measure and assessment that is rating the patients and tracking the patient's self-perception of their function, their performance in their problem areas and how satisfied they are with their function. So it's great. It's a standardized assessment, but we're able to use it to help assess the client's own self-perception of their function and satisfaction over time. To track daytime sleepiness, which is different than fatigue, we look at the Epworth Sleepiness Scale. I mentioned the DBAS dysfunctional beliefs about sleep. The stopping is a screener for sleep apnea, which does have a very high comorbidity rate with insomnia. So stopping is a screener for that. And the morningness, eveningness questionnaire is also a screener for circadian rhythm disorders too, which can impact and help us determine what's the optimal timing for somebody's sleep. So kind of to sort of theoretically tie everything together, on the left, we have the components of CBTI. We have some of the topic areas, especially we see show up around sleep a lot, from lifestyle redesign, helping somebody form health promoting habits, modify their routine, improve their time management, their stress management, and overall sense of activity balance. And then within a session itself, to practice lifestyle redesign, you do need to be trained in motivational interviewing. So within a session, we're always using MI to strengthen someone's inherent motivation for change. And also as an OT, something that we're always looking at too is the individual's context. So again, assessing the environment and how that's can be a facilitating factor or barrier to somebody's sleep, but also their daytime participation as well, and other contexts the individual is living in too. So on that macro level. Okay, this says case studies. We're doing one. We only have time for one. So this is our case study that I'll be showing you and talking about. And I'm excited because I think she really does a big critique, I guess, in the behavioral sleep medicine world is people feeling like, well, there's a difference between like, that's nice to see sleep restriction data, but good luck getting a real life person to do so. So I hope this can really illustrate, like how this works in real life, I promise. So our case study is a woman with insomnia, but also other conditions as well. So this was a 68-year-old female with history of insomnia. But her prior medical history included sleep apnea. So she's coming in with comorbid sleep apnea. It was managed though, so that was a stable factor. But she also would experience AFib that was triggered by GI symptoms. This was also impacted. Her GI symptoms would be impacted by what she ate. So mainly things that was like gluten, sugar, or like fried foods. Spicy foods, and also the timing of her meal. So she needed to have adequate timing as well. Her self-report of some sleep baselines was her self-reported sleep time. So this is just when she got into bed, could be anywhere between 9:30 p.m. to 1 a.m. And sleep end being anywhere between 4 a.m. to 8 a.m. So high level of variability in her sleep routines. And then within that, her sleep onset latency was about an hour or so. She would wake, and then she self-reported like she could have anywhere between 1 and 2 awakenings, but those would be long awakenings, so up to an hour. And then she would also have early morning awakenings of variable duration. So sometimes she would wake pretty soon when she wanted to, but sometimes it would be an hour or more. And then because her sleep was so fragmented, and that also is then compounded by sleep apnea, which also in fact impacts the quality of her sleep, she's a pretty frequent napper, so napping up to an hour every day. In her occupational history, a lot of her daytime routines revolved around her own healthcare appointments and caregiving for her mother. So she spent a lot of time attending appointments. Her physical activity, though, was pretty consistent. She would spend time gardening in the morning. So that was always kind of a consistent part of her day. And then she would move into, her own health management or being a caregiver for her mom. But she managed to have other sort of meaningful roles in her life. She would be really social in the evening. She had a volunteer role a few times a week. So each evening, that was kind of her time, but it ended up looking quite different. that could impact the timing of meals and the content of her meals, in addition to also impacting just the timing of sleep. It was impacting this other area of health management occupation, her eating routines, which also it then impacted this other chronic condition, which could then impact her sleep. So lots going on. I saw her from July, and then I actually discharged her about a month ago. So I saw her for 9, and sorry, this should be like 9 total sessions until December 11th. And it says discharge 2/11. That should have said 12/11. So we had our eval. We had 7 follow-ups that were more consistent. And then we had a check-in at the end of October, and then sort of our final check-in discharge wrap-up session at the beginning, mid-December. So that's sort of what the overall duration and frequency. The topics that we address. So what do we like actually do in the sessions? Always start off with sleep education, providing the overview of, what is sleep, sleep drive, circadian rhythm, and then education into that I gave her education on the 4-process or 4P model of insomnia and why we developed CBTI, what is CBTI, all leading up to getting her to do sleep restriction. So after doing her diary, after getting her baseline, and after giving that education with the MI, she was pretty motivated to start sleep restriction. So once we started sleep restriction and we implemented the aspects of stimulus control, if you can't, of the practice, if it's not happening, we do want you to leave bed when you can't sleep. She did respond to sleep restriction pretty soon, and start to understand the benefits of it pretty soon, which then allowed us to really look at, how can we build awareness through self-analysis, problem solving, and then really focusing on the orchestration of what's happening in her evening, to both support her sleep onset, that she's feeling actually ready for bed at the time that she wants to, and also to reduce the risk of exacerbating her symptoms. So, and making health, and also like improving time use patterns, so she has time to make better choices, more health supporting choices around her eating routines. So our outcomes, so pre to post, here's sort of what the journey looked like for her. So at time of eval, her insomnia severity index was 18 out of a max 28. And by the time we discharged, she was down to a 4. So that corresponds to a clinical insomnia presentation of moderate severity to no clinically significant insomnia. Hooray. Her Epworth sleepiness scale, at time of starting, we do use it when we do sleep restriction. We use that measurement as well. So she was a 13 out of 24 before we started sleep restriction, which was considered moderate excessive daytime sleepiness. And then at time of discharge, she was down to a 2 out of 24. That's normal. Her sleep efficiency at baseline, so that's again the ratio between how much time was she giving herself to be asleep and how much time was she actually sleeping. She was sleeping 70% of the window she gave herself to be asleep, indicative of that's an insomnia sleep pattern, to 90%. That's within normal limits. For adults 65 and up, we look at 85% as our goal. And she was above goal, so she was at 90%. Her average sleep quantity, when I calculated her sleep diary at first, was 5 hours and 45 minutes. And at time of discharge, she was sleeping on average 7 hours a night. So within the recommended amount, and overall 21.7% improvement in sleep quantity. And then I was able to, so when I do sleep restriction, I do track their progress over time. I record it visually so they are able to see themselves, their progress over time. So the top line is her time in bed and the yellow line is her total sleep time. So you can see at week 1, and since she was motivated, I went off of 1 week of data. Sometimes people use 2 weeks of data before they start. I used one. So then we jumped right in, and you can see that it's just it's always great to see. And I never stopped getting joy of this as a clinician, of seeing like taking away someone's opportunity that doesn't need to be there, and getting them on a consistent sleep schedule will improve their sleep quality, because it's more efficient sleep, it's less fragmented, and this is the way to actually increase their sleep quantity over time. It's interesting too, it went down at week 7. You can see it went down. Week 7 is a little bit of a misnomer, because we went these periods of time where we didn't see each other. So that was week 7's really the last time I saw her. And so it went back down. So you can see that's about like a little less than 8 hours, but she's averaging 7 hours. That for her, it went back down because she felt that that was the most sustainable sleep opportunity window for her. I believe she was at like a little after midnight to getting up a little bit around 7:30, 8-ish. So that's, she felt was like it does kind of pan out. I don't need to try to get 8.5 hours of sleep time in bed. I can kind of keep it a little bit more around 8 hours. So that's why I went down. And then, yeah, I'll give it back to Lindsey to wrap us up.
Great. So with all that information, now just kind of thinking about, when might a referral to occupational therapy to address insomnia be appropriate? And if a client is expressing an interest in trying a non-pharmaceutical approach, or they're reporting some of those poor sleep hygiene routines, or just an overall lack of routine and structure in general, and you think that could be impacting their sleep, that would be a good time to refer. If they're reporting they're doing a lot of activities in their bedroom environment, things like that. But then also, if this poor sleep is then having a negative consequence on their daytime activities, participation in work or school or other self-care routines, those would all be a time to refer. And then if you do refer, just something to consider is that our services are covered by Medicare and PPO plans with a referral. You can go to the next slide for me. And we typically do one-on-one sessions either via telehealth or in our office. We'll do a complimentary insurance benefits check to let the client know what services are covered and what their copayment might be. And then we do also offer some self-pay options as well. And then lastly, we included our contact information below in case you have any follow-up questions after today's presentation. And that's all the information. I think we can get into some questions. We have some time for that. So looking forward to answering any of your questions.
Excellent. Thank you so much, everyone, for joining our winter symposium. We'll now move into the Q&A portion of the webinar. Please submit your questions using the Q&A feature in the chat feature, and we'll address as many as we can with time that allows. We have already one question from a participant. It says, any recommendations for improving sleep for patients in a hospital setting? Theoretically, is a barrier to restorative sleep in a hospital not just related to illness, but could it be related to the fact that the sleep environment, a hospital room, is where people are eating, doing PT, visiting with family, not just sleep and sex, hopefully not in the hospital, but the sleep environment is where everything is happening. Any recommendations to overcome this?
That is a great question. And I think that really just speaks to like the individualization and the need to really modify these recommendations to meet the client where they're at. We mostly work in an outpatient clinic, so this isn't coming up a lot, but some things that come to mind for me are first and foremost, just thinking about the routine. So if the sleep is really important to sort of manage, I think it's important that adhering to some sort of routine is also then communicated with the clinical care team that the client is working with. And that might look like, how can we reduce nighttime disruptions? How can we prioritize PT and OT at certain times of day so it's not interfering with sleep? And just communicating that goal with the clinical care team. Environmentally, whatever we can do to manage noise and sound, whether that's earplugs, headphones, dimming the lights, so that it isn't this like constantly overstimulating environment. but then also incorporating calming environmental factors, calming music, again, dimming the lights, just setting up the environment to at least support sleep a little bit more optimally. And then I do still think, going back to that routine idea, like I do still think there's opportunity to create a wind down routine, even though all your activity is happening in that hospital environment. There still could be things that you're doing each night in preparation for sleep to kind of cue the mind and body that we're promoting relaxation and preparing for sleep. So those are some ideas that come to mind for me. I don't know if Anna, you have other thoughts, but
Yeah, and yeah, like both Dr. Shomer and I work in outpatient. So in terms of, but this is something that like comes up when I presented like at other conferences, like inpatient and residential settings, I think is a real challenge. And that challenge can come really from the environments, in addition to everything Dr. Shomer mentioned with like individualizing within the patient's context and also within your team. What things that I have read of really kind of advocate also for aspects of like stakeholders who could support making like sort of larger scale environmental changes within the built environment, and also like both for nighttime sleep and reducing barriers to nighttime sleep, making sure we can find ways that across the board that rooms are as dark as possible, as quiet as possible, and also during like how for patients who also then might need stimulation during the day, because that's the other piece of like getting wake promoting signals to your circadian rhythm, and also supporting sleep drive, which I think are factors that are really hard to do for a variety of reasons in hospital settings or inpatient or residential. It's like that's also the other side of the coin too. It's like what's also happening in the environment that supports the alerting cues of their circadian rhythm during the day and supporting their sleep drive also building during the day.
Thank you so much for sharing that.
Yeah, I just wanted to add that in a hospital environment like at Children's Hospital, sometimes we'll speak to the attending subspecialty service to ask about uh, less frequent, visits for vitals. That becomes because, you end up waking the child multiple times in the night. You have to sometimes when they're more acutely ill, but as they're starting to stabilize, you could reduce that visit, from Q30, Q2 hours to something like Q4, depending on what's going on with the status of their conditions. Those are really good options in the hospital setting too.
Thank you, Dr. Gold. From a clinical standpoint, how do you decide when to lead with lifestyle redesign strategies versus CBTI techniques, particularly in patients who feel overwhelmed with more prescriptive interventions like sleep restriction, per se?
Yeah, I think it really begins with kind of assessing the patient's readiness for change and where they're at. Sleep restriction is very restrictive as it sounds, and so that's typically not our starting point. I know personally, and I'll let Anna share her experience too, I like to try to make these adjustments in other areas. Let's reduce activity in your bedroom. Let's create that wind down routine, and really focus on like the self-regulation strategies and other things that feel maybe a little more accessible as a starting point. And if those things are making sufficient changes, great. We may never have to get to actually the sleep restriction piece of it if their sleep is improving. But if their sleep is improving and they're seeing the benefit of that, that may also increase their motivation to then try the sleep prescription route or sleep restriction route because they're already noticing some of the benefits of it. So I tend to kind of start with that lifestyle redesign approach to get the buy-in and the motivation and kind of the experience of the changes before jumping into the restriction approach.
I go this, and I think this is great that you're getting both of us because I tend to go I tend to flip.
Love it.
And the reason, but but I also end up flipping to lifestyle redesign like first. And so what I'm looking for is like readiness for change. And I think always too, like the sleep diary, like the consensus sleep diary also like tells me a lot, like how severe is their insomnia that we're working with. And also something we see a lot at our clinic are complex conditions and comorbid conditions. So when they're with their sleep or insomnia symptoms, how much of that is conditioned arousal and how much of that is other symptoms that they're experiencing? That I think gives me a lot to work with. And then there's, going back to the two process model of sleep, there's things inherent in that of like getting on a schedule, building your sleep drive, regulating your circadian rhythm. There's so much about just focusing on that is lifestyle redesign. So that's, I think, and then to kind of like build upon what Lindsey said, like if that's what we also just start focusing on and start to also continue to do something where we can track their results and get their subjective input, that's already building the process of radiating change too. And it gets them to understand. I'm a big proponent of having them also have sleep not feel so mysterious to them. So I really try to reinforce that they are making the connection between like what they're doing and how it's affecting their sleep physiology.
Yeah, I just wanted to add to that because I really like that you mentioned the comorbid health conditions because a lot of the patients that we treat have comorbid, cancer, GI issues, endocrine. I work with a lot of patients with chronic pain. 100% of kids with chronic pain suffer from disordered sleep or sleep disorders. And just that sleep hygiene part where you try to clean the bedroom out because most kids and teens are they're on their phone, they're on their laptop, they're doing social media, they're reading, they're eating, they're watching TV, they're playing games, video games. I mean, their bedroom, their bed, their sleep environment is just full of all of those non-sleep activities.
Mhm. We received
So
another question.
yeah.
Any recommendations on resources we can share with patients to support restorative sleep, such as meal timing, sleep hygiene? Any thoughts on supplements such as magnesium or melatonin?
Yeah, yes. Um, so I'll touch on, I think, some of the things you said. So meal timing, when we talk about sleep hygiene strategies, we do just try to encourage people not to eat too late in the evening. Usually we want to have like a 2 to 3 hour buffer between their last meal and the time they go to sleep. The reason for that is that metabolizing food is a very active physiological process. And so that can kind of be counterintuitive to trying to go to sleep. So we want to have some downtime, metabolize the food before going to sleep. You said eating routines. What were the other parts?
Sleep hygiene, any recommendations or resources that they could share with patients to support restorative sleep?
Yeah, so in our clinical practice, we have a variety of patient handouts. I don't know, Anna, if that we often give to clients, but I don't know if I like
Yeah,
getting these
if I would,
online.
yeah, in terms of resources, yeah, like I'm trying to think of anything, and a lot of my resources online are for like clinicians. But the book I recommend to people, I recommend people to in New York at a hospital. Okay, so you might need something like handouts. Last time I checked the CDC, it does have like pretty, like I've directed patients to there, tends to lay out. So again, the last time I checked, I don't know if things have changed. At a hospital, it might be hard to recommend to people. What resources that I give that's not from our clinic that I would recommend people to read is a book called Quiet Your Mind and Get to Sleep, by Rachel Manber and Colleen Kearney. It is a very user-friendly book on cognitive behavioral therapy for insomnia, and includes all the tenets of sleep hygiene, but it's a book, and not like a digital resource.
Okay, so we're at time with questions. I'm going to pass this to Dr. Gold to wrap us up.
Well, I just want to thank you all for being here today and presenting this very compelling and innovative work that you're doing around sleep hygiene and sort of restorative sleep and how important it is. I mean, I don't think anybody mentioned it, but by the time you're 30, you're technically supposed to have slept 10 years of your life, which just really annoys me from a productivity standpoint. Like there's so many things I'd rather be doing with those 10 years of my life other than sleeping. But we know that community of folks like to sleep, and that's really important, obviously, for us to be productive and to live a healthy life. And so I really appreciate you presenting on this topic. People are fascinated with sleep, with sleep behaviors. People are interested in dreams associated around sleep. I mean, it's really it's really a fascinating landscape to say the least. And so sleep architecture and everything that comes with that. So just really want to thank you for being here and for presenting to our community. This will be available as a recording on our USC IIHW YouTube channel. And looking forward to creating more traffic and more education for our communities. And then also, as I mentioned at the beginning of the talk, we're going to have some other symposiums and some book signings and book readings coming up, some in person and some virtual at USC. So please sign up for our listserv at the USC IIHW website and come join our community and participate in more educational symposiums and as we're working towards our health and healing. And so again, thank you all for being here today and for imparting your wisdom, your expertise, and I hope that this will be a really prosperous year for everybody, and that we'll all be connecting again real soon.